Hello and welcome. This short video will provide you, the medical control physician from Milwaukee County EMS, with an overview of the 2019 guideline updates. As a reminder, these updates will become operationally effective on April 15, 2019. For this presentation, I will be fairly concise with each of the guideline updates, only occasionally getting into the background and rationale behind each update and protocol. Dr. Colella provided a much more detailed presentation to Milwaukee County EMS providers that was recorded, and I will provide the YouTube link at the end of this presentation. We will start with an update to the hospital destination and transport policy. You can see here the designated specialty centers. There has been a change from ROSC hospitals to resuscitation hospitals to better capture the nature and function of these specialty centers. Additionally, there is the inclusion of the broad category of emerging infection. Under this section of the hospital destination and transport policy, there is clarification on burns in those less than 18 years old going to Children's Hospital. Additionally, hyperbaric oxygen therapy has become a specialty care designation. Finally, there is a note that OB patients should ideally go to the hospital where their care has been established, but all EDs are capable of care if delivery is imminent. Just as an FYI, you can see here the difference between bypass conditions, which implies the facility has a major internal emergency requiring facility closure, such as structural damage or a security issue, as opposed to limited divert, which applies to diverting patients under a certain designation, such as bypassing STEMI patients if the cath lab is down. Next, in the acute coronary syndrome guideline, there is no limit to the doses of nitro that can be repeated as long as the systolic blood pressure remains above 100 millimeters of mercury, and there is no use of phosphodiesterase inhibitor in the past 48 hours. Other nitro contraindications include inferior wall STEMI, right ventricular STEMI, heart rate greater than 100 in the absence of heart failure or bradycardia less than 50. Additionally, nitroglycerin and/or fentanyl may now be given in certain circumstances. In the airway management guideline, end-tidal CO2 should be used with the bag valve mask as well as before and after any airway placement. A king airway is generally the preferred airway for the uncomplicated sudden cardiac arrest. In cases where sudden cardiac arrest is suspected to be the result of bronchospasm, poor lung compliance, or angioedema, a video-assisted endotracheal intubation should be attempted. Finally, if the end-tidal CO2 does not seem to fit with your patient's status after airway placement, do not anchor on equipment failure, but rather suspect an unsuccessfully placed airway. In the burn injury guideline, note the exclusions for going down this pathway, and going to a burn center would be thermal injuries resultant from major trauma or isolated carbon monoxide exposure. Also, in cases of burns with shock, consider other possible contributing factors, such as cyanide or carbon monoxide exposure. In the cardiac arrest guideline, the main change to emphasize this time around is that in cases of refractory VFib with the Lucas in place, scene time should be minimized, and the focus should be on rapid transport. Online medical control may still be called for in these situations, so the message for these cases with Lucas in place and refractory VFib should be load and go to the closest appropriate hospital. In these specific cases, as appropriate, you can encourage continued transport and following their protocols for ROSC or rhythm changes, and not have you, the online medical control doc, stay on the line. Now for a few more abbreviated changes. The major take-home point with the LVAD guideline is that in low-flow alarms, consider that the patient may be dehydrated as the pumps are volume dependent. In the nausea and vomiting guideline, consider prolonged QTC as appropriate when given QTC prolonging medications, and Benadryl may be used as an adjunct in patients with nausea and vomiting. The OBGYN considerations guideline now encourages referencing the shock guideline for cases of continued shock. The patient restraint guideline here outlines a single drug approach to chemical restraint using doses of ketamine. Ideally, it's encouraged to try to stay with one drug, but you can exercise judgment if you need to escalate drugs while using capnography for patient monitoring. The ROSC guideline now outlines when it is being used, the ITD should be removed once ROSC is achieved. In the shock guideline, trauma is now delineated to with or without head injury, Those without head injury should not have a repeat bolus, allowing for permissive hypotension. Here in the syncope guideline, should you receive a call about a patient transport destination question, certain high-risk features listed in the middle diamond outline those that need to be transported by a paramedic instead of BLS level transport. Finally, in tachycardia with a pulse, this guideline should only be used in adults with a sustained heart rate greater than 150. Diltiazem may be administered after volume issues are considered and other contraindications as listed are ruled out. Below are links for Dr. Colello's more detailed discussion of each of these protocol changes, as well as the online link to Milwaukee County EMS guidelines. Additionally, you can find the handy phone and tablet app by searching the App Store for MCEMS. Thank you for listening, and as always, thank you for your contribution to pre-hospital patient care in our community.